All right, hello everyone. We're back here with another presentation. Today we'll be talking about clinical reasoning in the respiratory system. So just be going through a bunch of different conditions and what you can expect to see on history, exam, investigations, and just a bunch of different buzzwords that faculty loves to use in exams. All right, so we'll be starting off with COPD, chronic obstructive pulmonary disease. There should be probably a lecture on this in asthma, very in depth. So focus on that and then come back here for the little buzzwords. So on history, you've pretty much got a cough. That's its main thing. It's a combination of chronic bronchitis and emphysema. So you're expecting a bunch of productive cough. Shortness of breath, wheeze, past smokers. That's a big thing. One of the biggest reasons people develop COPD is either past smoker, which is a lifestyle modifiable risk factor, or alpha-1 antitrypsin deficiency, which is a non-modifiable genetic risk factor. On physical exam, there's a bunch of different signs that should be talked about in clinical skills or in Tally O'Connor. I guess the big ones are, you're short of breath, so you're probably gonna have high respiratory tachypnea. Pursed lips breathing, that's just basically because they're not getting enough air in and out of their lungs, they're having trouble breathing, and that also leads to cyanosis. For some reason, they like to people who present with COPD like to lean forward, and that helps them short of breath. I think that's in general with the diaphragm movement and all, and use of your intercostal, your accessory respiratory muscles. Hoover signs are a special sign. They talk about in clinical skills. Tracheal tug, so that's one of the things you can mention in your physical exam. When you're seeing your trachea, it can either deviate or it can tug down on each movement because of all the hyper expansion of the lungs because of air trapping. Hyper resonant lung sounds because, again, of the air trapping. Early inspiratory crackles, reduced breath sounds, sort of intuitive. On investigation, so the things you'd order a spirometry and you'd see low FEV1 over FVC ratio because it's an obstructive disease. And the difference between this and asthma, which are the two obstructive diseases, this is irreversible when you administer a bronchodilator or a SABA. And there's also increased TLC. And management, there's a bunch of different tiers, but overall you start with SABA or SAMA, move on to a LABA or LAMA, sorry, I'll fix that. It's a LAMA, that's a capital L, it's supposed to be. And then you add on an ICS with a LABA and a LAMA, so all three. Yeah, so these are the main presentations, or okay, we'll talk about the presentations first. There's these two things I've actually also talked about, and I was a bit confused, but I'll walk through these. Essentially, COPD is made up of 1 chronic bronchitis and 2 emphysema. And so there's 2 different pictures you want to have in mind. One that mainly relates to chronic bronchitis, one that mainly relates to emphysema, but naturally it's a combination of the 2. So chronic bronchitis, we call them blue bloaters. Blue because they are cyanotic, right? So bronchitis is buildup of a lot of sputum, purulent sputum in the lungs. So they have this chronic productive cough, and because of that, they're not getting enough oxygenation of their blood. The airflow is just ruined. DLCO would be decreased. There's a bunch of edema, crackles, and wheezes, but essentially they're blue because they're cyanotic. So you want to think that chronic bronchitis, cyanosis sort of go hand in hand. Pink puffer, on the other hand, is the emphysema part where the distal alveoli, the distal bronchioles sort of break down, they combine, and it just is bad for the oxygenation of the blood. But they're pink because they're using all their accessory muscles, their intercostal muscles, their scalenes, and that essentially, because of the blood flow to those muscles, they're supposed to be a little pink. They're also very frail, and they're more at risk of a pneumothorax. If we look at a COPD X-ray, I guess A, B, C, D, F, G, H. I'm not going to go through all of these for all of them, but if anyone ever asks you for a chest X-ray, just go through this. It's really important to be systematic. And if you just go through describing each one of these characteristics, I think just have this imprinted in your mind. We use this all the time on the wards and stuff. So you first look at the airway. You're looking if it's deviated, if you can see it, if the penetrance of the X-ray is good enough. Looking for any bony fractures. and note, you're not only looking at the ribs, but sometimes a clavicle fracture, scapula. You can see a bunch of different things that should be obvious and should stand out. Cardiac, you're looking at cardiomegaly if the borders of the heart are clear. I mean, there's a bunch of different things to talk about in each of these, and I'll highlight the main ones. So in COPD, you're mainly looking at the diaphragm. So I think normally the diaphragm are supposed to have a much steeper curve, but because of the air trapping, because there's trouble getting air out of the lungs, it almost, it's sort of just your lungs hyperinflate, and there's overexpansion of the lungs, and that literally pushes down on your diaphragm, causing them to flatten out. So normally your diaphragm would not be this low. All right. Next up should be pneumonia. Yep, pneumonia. So in medical history, they would have a first starting dry and then productive cough. It's an infection, productive. So you're looking at the color of the sputum, expecting like greenish if it's like bacterial, because of the inflammatory infiltrate. Fever, because it's an inflammation, infection. Yeah, chest pain, dyspnea. These all should be fairly intuitive. Your rigorous confusion are sort of in very severe cases. They're not in normal pneumonia, maybe in like immunosuppressed or such. On physical exam, so we talked about the fever. Mainly you're looking at crackles at base. That's a very common sign because if there's infection in your lungs, there's going to be a bunch of inflammatory infiltrate, and that is usually in the form of fluid accumulating in the alveoli. And anytime there's fluid in the alveoli, you'll hear crackles. That's an important sign, easily show up in exams. Reduced breath sounds, again, because of the inflammatory infiltrate. You sort of just want to think of the pathogenesis, which you probably talk about in microbiome, hopefully. But if there's an infection, you got fluid coming into the alveoli, and all of these signs are just because of that. So increased vocal resonance, this was something I had a lot of trouble understanding. So I've got a slide later on where we break that down on when vocal resonance increases or decreases. The gold standard, I think, on investigation is consolidation on chest X-ray. So the next slide should show that. Consolidation is just a more opaque region in the X-ray, and that's, again, because of the inflammatory infiltrate. And you sort of just use antibiotics or antimicrobials. Oh, okay. Slides are a bit out of order. Here's the pneumonia X-ray. So if you look at this, right-sided, probably in the lower or middle lobe, it's hard to tell. You see this white patchy infiltrate or consolidation that you don't see on the left-hand side. As you should know by now, the lungs should be relatively dark with these lines indicating the blood vessels and the blood flow to the actual lungs. Okay, asthma is your also other main condition. So main thing you're looking for in history. Again, you go into this in much more detail in your specific lecture, but overall on history, you're looking for a cough that's for some reason worse at night. And there's certain typical things that exacerbate it. So some people it can be exercise, some people it can be cold weather, some people it can be very specific triggers, such as in times of hay fever and such. Yeah, I think even certain foods can exacerbate it, but yeah, you're looking for specific exacerbations. And a big thing that they'll show, put in exams is like a family history of the atopic triad, which is your dermatitis or eczema, asthma, and your allergic rhinitis or hay fever type of stuff. On physical exam, Harrison sulcus, I don't even know why it's there. It's a very niche sign, don't even know that. Expiratory wheeze, huge thing. Faculty will always describe asthma as an expiratory wheeze. Inspiratory, remember, if you hear a wheeze-like sound on an inspiration, it's called a stridor. In expiration, it's a wheeze. Tachycardia and pulsus paradoxus, again, I thought it was a niche thing, but apparently for clin skills, we're supposed to know it. It's a large decrease in systolic blood pressure during inspiration. And it's normally in children with asthma, it's a very telltale sign of asthma. So if you're checking blood pressure on inspiration, their systolic blood pressure might drop down from 120 or whatever to 180. I don't know what the normal range is. Investigations again, spirometry, but this time you'll have your low ratio, which is indicative of an obstructive condition. But then what you do is you provide a bronchodilator, SABA, so your Ventolin puff or whatever, and then you check spirometry again, and it should increase by 200 milliliters or 12%. So those are two important numbers to know. So just, yeah, if it improves after spirometry, it's asthma. If it doesn't, it's COPD. And again, there's a huge stepwise approach, but overall, SABA, steroid, LABA, ICS, it's a, yeah. TB, tuberculosis. Okay. TB almost presents, it has a very similar presentation to cancer, actually. So it's an infective cause, but it's not as similar to pneumonia as it is to cancer. So you have someone with their main systemic symptoms, right? Fever, night sweats, weight loss, hemoptysis. Hemoptysis is blood in the sputum. And travel history or country from high risk. There'll be a lot of like either East Asian countries, Southeast Asian countries on exams. That's what they'll use. So keep an eye out for that. You want to be thinking TB right away. Granuloma consolidation at the apices. This is a very telltale sign. It's sort of where TB stays, what's the word? Dormant. It stays dormant in the lungs, and it sort of forms this granuloma, which is just, it's essentially hiding from the body and hiding from immune cells by surrounding itself with, yeah, a granuloma. And you can see that on chest X-ray. We'll have that chest X-ray. You got your RIPE therapy, your rifampicin, and all the other stuff. And yeah, just a cool fact is that estimated 1/3 of the world's population is actually infected and 90% is asymptomatic, again, because TB can stay dormant. And yeah, so you'll get these chest X-rays done, and you'll see these almost fibrous granulomas at the top of the lungs this time. I think it's mainly on the right-hand side over here, but yeah, you want to be looking there for TB. But yeah, big on history as well. Your history will always help you get 90% of the way there, and then you look at investigations. PE or pulmonary embolism. You got your sudden onset pleuritic chest pain, which is pain on like breathing and stuff. Shortness of breath, of course, because there's chest pain, they're not breathing as deep or heavy, and possible syncope. But the main thing you want to know in medical history is this history of surgery, DVT or deep vein thrombosis, or just being immobile for a long time, such as a flight or a long car ride. These are all very telltale signs. And if someone has like calf pain, that's another big telltale sign, because your deep vein thrombosis, that's in your calves. On exam, they're tachycardic, high heart rate, tachypneic, high rest rate, and you hear this friction rub, which is essentially because you've got the embolus in your pulmonary vasculature. There's a bunch of inflammation, and friction rub is a thing you hear on auscultation, where your pleura are essentially rubbing together, and it's big on inflammatory conditions where you hear that. Fever makes sense. Elevated JVP. Yeah, those are mainly, you want to be looking at history for PE. And then you've got some investigations, your ventilation perfusion scan, how different areas of your lung are ventilated, which is your air, and perfused, which is your blood. So obviously, if you've got a big PE, that blood flow is the part that's going to be obstructed, and so you'll see less perfusion in certain parts of the lung. And the lungs are very smart in adapting to that decreased perfusion, where they would actually shunt air away from that area, because those parts of the lung are essentially useless. And then some other tests you can do, angiography and D-dimer, which will just, angiography will show you where the blockage is, and D-dimer is just an inflammatory indicator, and pretty sure it can only be used to rule out a PE and not actually rule in. Yeah, it's a specific thing. Management, your heparin is your like blood thinner type of thing, and you might require surgery. Okay. Just about the surgery, there's one thing called Virchow's triad, which you'll talk about later in SEM 2, but it might be something interesting if you want to look at. And essentially a triad of different scenarios where your blood is more likely to clot. And surgery, I think, pretty much fulfills all three. It's like endothelial cell injury, immobilization, and just being more prone to clots. Sorry, I don't know what my slides are doing. So that's why people always after surgery will be, or on the wards and stuff, because they're also immobilized right after surgery because they're just lying there in recovery. They'll always be on an anticoagulant or antiplatelet of some kind. What's up next? Yes, this is just a diagram of how DVT, deep vein thrombosis, can lead to a PE. So you've got these veins in your leg, and if you think about it, those veins are feeding all the way up and directly into the IVC and into the heart, into the right side of the heart, where into the right atria, and then the right ventricles, and then right out to the lungs. So the lungs are essentially the smallest capillaries that this clot, starting all the way in the calf, will first meet, because everything else before that is pretty patent. And that's where it'll lodge and you'll present with PE symptoms. Pleural effusion. So that is a consolidation of fluid between the two layers of the pleura, the parietal and the visceral. You present with shortness of breath, as with almost every other respiratory condition, but it's associated with these different conditions, which as you go through these different systems, it'll make more sense. But I guess you've done cardiac, so we can talk about heart failure. Heart failure often presents with edema, and pleural effusion is essentially a form of edema, where you've just got this excess fluid and it sort of leaks out into the pleura. Stony dullness on physical exam is a huge buzzword that faculty just loves to use. It's on percussion. So normally you're percussing the lungs and they're resonant because they're filled with air. But when you come to a pleural effusion, because there's liquid there, it's obviously not going to be resonant anymore, and it's described as a stony dullness. Some breath sounds, pleural rub. Remember the pleural rub on auscultation I described earlier. Decreased vocal resonance, again, we'll talk about this later, and possible displacement of the trachea. The big sign, blunting of the costodiaphragmatic angles. So I think I have an X-ray, yep. So essentially, okay, if we look on the left side of this chest X-ray, you'll see where, okay, if we costodiaphragmatic angle. So you've got your costal, which is another word for your ribs. So you're looking at and diaphragm. So you're looking at where your ribs and your diaphragm meet, which is at this specific point. I hope you can see my cursor, but at the bottom right of the picture, sorry, not of the lung. You've got this sharp point where they meet. And anytime that's blunted, so on the left-hand side, on the right lung, it's very obviously gone, right? Because there's all this fluid in the lung. But it doesn't have to present this massively. It doesn't have to be such a massive pleural effusion. If this angle is gone at all, such as if this line just continues straight down and you don't see this sharp point, that would still be considered a pleural effusion, because the only thing that really blunts this angle is fluid between the two pleural layers. Okay, what else did we have? Yeah, management, you either treat your causative condition, which is these ones, which can cause increased edema, and you drain the effusion. Pneumothorax. Pneumothorax is essentially a sort of lung collapse of sorts, but it's, yeah, you present with sharp, rapid onset chest pain, and a very typical picture the faculty might paint in exams as a tall, thin young male, and what they're alluding to is Marfan syndrome, but they might use like a basketballer as an example. And there's a bunch of different causes which will lead to different types of pneumothorax, but it can either be due to trauma, emphysema, iatrogenic, which is caused by medical procedures, or Marfan syndrome, you just had a higher propensity of your connective tissue diseases. On physical examination, so you've obviously got your dyspnea, your tracheal deviation. So in a tension pneumothorax, your trachea and actually your whole mediastinum, but mainly your trachea is most obvious on chest X-ray, will shift to the opposite side of the lung collapse, of the pneumothorax, right? And so if you have a pneumothorax, obviously your lung's not there anymore. It's shrunk down. You'll have reduced breath sounds, and they'll be hyper resonant. So even though your lungs are filled with air, they're also filled with a bit of fluid. They're filled with the blood vessels and other stuff. But once that's all gone, then it's literally only air in the chest wall. So it will be hyper resonant, so a lot more resonant than you're expecting on percussion. And there's decreased movement of the chest wall. So your chest X-ray can be used in diagnosis. And my example is a very severe example of this, but it's most likely what you'll be seeing on an exam or in a tube. But CT can be used for milder forms. And you essentially use this flexible tube or a needle to remove the fluid, if there's any fluid, or to just release the pressure. And once you release the pressure, the lung should reinflate. Okay, so yes, the lungs are normally dark and they're pretty grayish on chest X-rays because they're filled with air. But seeing these little lines of slightly opaque regions is normal on the left lung, on the right lung. There's still blood vessels, there's still some fluid in the lungs. When you see absolutely no vasculature, such as seen on the left lung, that's when it's concerning. And if you look closely, you can almost see an outline of the remaining lung after the pneumothorax. But yeah, so a big telltale sign on chest X-ray is this complete loss of any vasculature on in the area that your lungs would be in. Interstitial lung disease, I'd say it's relatively low yields, but you have this dry, persistent cough, and you have these certain specific chemicals in occupational exposures that may cause it. You will hear crackles. I believe it's more fine crackles than the crackles you might hear in like pneumonia. And you've got these different signs on physical exam. Yeah, see fine crackles. So it sounds more like Velcro. And because of the reduced DLC or reduced oxygen, your alveoli just aren't working as well. You'll have some cyanosis, some decrease in oxygenation. On investigations, you can either do chest X-ray or CT. In terms of imaging, you'd also likely do spirometry, and you'll have a decreased total lung capacity as well as decreased DLCO because of alveolar dysfunction. You mainly use steroids or inhaled oxygen to help treat or manage that. Cystic fibrosis, I say, would be a bit more high yield, but still low down on the list. But it's more of a systemic, it affects a bunch of different organs, and how it can affect the respiratory system is you get that, you get recurrent chest infections, and the whole physiology and the genetic mutations on that you would have talked about in class a lot. But yeah, you're looking for a baby who's having poor weight gain and growth, and they also present with greasy stools. And you mainly diagnose this or investigate this with a heel prick that's done for every child. And it detects most of them. And you also have a sweat test at 6 weeks, which basically is testing the whole physiology of how cystic fibrosis develops with the sodium chloride and stuff. And management is, again, it's very multidisciplinary, it's broad spectrum. You need physiotherapy for your chest, high calorie diet because your pancreas isn't working ideally, antibiotics because you're susceptible to recurrent chest infections, and you may need a lung transplant in severe cases. Whew, how much do we have left? All right, almost there. Carcinoma of the lung. On medical history, we talked about TB symptoms, so very systemic symptoms. You get your weight loss, your night sweats, and hemoptysis. Usually have a smoking history because that's a big cause of lung cancers. And you might have a hoarse voice because of your recurrent laryngeal nerve nearby. And loss of appetite is another systemic symptom. So you get Horner syndrome, which is what I'll focus on, is similar to weakness of T1 nerve root, but Horner syndrome is disruptions of the sympathetic supply to your head, and it has this triad that it presents with, which we'll talk about in the next slide. Sorry. Okay, in terms of investigation for the carcinoma, you can either do chest X-ray or CT, but you also want to take a bronchial biopsy just to guide treatment and see if it's malignant or not. You might also see enlargement of the carina just based on where the carcinoma is, and you also want to check the nearby lymph nodes for any metastasis. And management, as you can imagine, would be pretty complicated with surgery and chemo. Okay, a bit more about Horner syndrome. So yeah, sympathetic nerve supply to one side of the face. Because of where if you look at the anatomy of where the carcinoma of the lung is likely to be, it's more likely to press on the sympathetic trunk or possibly even the T1 nerve root for the brachial plexus. But you have these three telltale signs, so meiosis, which is constricted pupils, ptosis, which is a droopy eyelid, and anhidrosis, which is failure to sweat. And the specifics of this you'll cover more in head and neck, but essentially your sympathetic nervous system will dilate your pupils. So if that's gone, it's constricted. Sweating is also mainly by the sympathetic nervous system. So it's dry, and droopy eyelid is very specific muscle in your eyelid that's controlled by sympathetic input. Pulmonary edema is one of your other conditions, which is like your peripheral edema. It can be secondary to heart failure on the right hand side. Sorry, on the left hand side, my bad. Left sided heart failure. I'll have to check that. But yeah, in terms of exams, pink frothy sputum is a big buzzword for this, and something that's worse on lying down, or your cough or dyspnea worse on lying down, which can often lead to orthopnea or paroxysmal nocturnal dyspnea, PND. In terms of physical exam, you've got the increase in fluids in your lungs. You can expect crackles because of the edema, and high heart rate, high resp rate as usual. In terms of investigation, your oximetry is better than chest x-ray for diagnosing pulmonary edema, but you can do a bunch of different, you can do bloods, ECG, echocardiogram. They'll all show different signs for pulmonary edema, but you mainly want to know how they present as history and exam at a year 2 level. In terms of management, there's a bunch of different guidelines for what to do, but your position, they'll want to be sitting up because it gets worse on lying down, because the edema sort of flow once they lie down because of gravity, it'll sort of spread all over the lung and just cause more coughing. You want to provide them with oxygen because they're likely have dyspnea. Sublingual nitrates can help with any vasodilation, which might relieve symptoms because it can be a cardiac cause. Morphine for the pain, and diuretics to sort of flush out all those fluids. All right, as promised, some more information on vocal resonance. So the basis of vocal resonance is on this one fact, which is sound travels better through fluid than through air, right? And so what you're listening for in vocal resonance, which if you remember is you're auscultating the patient's lung and you're asking them to say 99, 99, 99. So you're hearing those vocal vibrations and how they're traveling through the air or through fluid. And so when vocal resonance is increased or it's louder, you want to think there's fluid in the lungs. And so you're thinking your consolidation pathology, such as pneumonia or pulmonary edema, where there's infiltrate and fluid in the alveoli. And that's a better conductor of sound. And it doesn't change the distance between the lungs and the chest wall, as opposed to things like pneumothorax or pleural effusion. So what is a pneumothorax? Okay, we'll start with pleural effusion. You have fluid, which you think is a better conductor of sound, but the fluid is outside the chest wall. And so when you're auscultating, there's greater distance between your lungs and the chest wall. And so there's decreased transmission of those vibrations. So if you have fluid inside your lungs, you have increased vocal resonance because they're conducting the sound better. But if you have an increase in the distance between the lungs and chest wall, then there's decreased vocal resonance. And in pneumothorax, there's just a bunch of more air between the lung and the chest wall. And so there's less vocal resonance because that's a worse conductor of sound. Okay, a few questions.